Our second plenary session is going to be anchored by Dr. Imodoy Abioro. Dr. Abioro is a graduate of the University of Ibadan, a physician and avid computer programmer who is passionate about improving healthcare delivery in Nigeria, especially to those living in hard-to-reach areas, firmly believing in bridging this access gap with appropriate technology. He's the founder of the project Lend an Arm, a youth-focused voluntary blood donation awareness program and blood drive in Oyo State. Currently working with project partners, the project hopes to combat blood shortages in the Nigerian healthcare delivery system, helping the country to achieve 100% voluntary blood donation as encouraged by the World Health Organization. He has international experience volunteering with the SOS Children's Villages International, an organization supporting children without parental care and families at risk in 135 countries. So join me as we welcome Dr. Imodoy Abioro.
Good afternoon, ladies and gentlemen, and welcome to the second plenary session of the second General Assembly of the Federation of African Medical Students Association, Ibadan 2018. Today, we'll be talking about bad news, very bad news. Our session will be on disaster management. I'd like to inform you that last week Monday, the WHO Regional Office for the Afro region said that there are 50 current ongoing disasters and outbreaks across our region. We have only 47 countries in our region, so we have more problems than countries. This is the situation we find ourselves with the kind of disaster management system we run in Africa. And today we'll be talking about this system and how we can forge ahead, moving from a reactive disaster management system to a proactive disaster management system. Joining this discussion will be three international experts of great renown, and I will be introducing them shortly. First, we would watch a video. Afterwards, we would hear from one of our panelists, Mr. Adam Thompson. Mr. Adam Thompson is an information systems analyst specializing in social sector organizations with a passion for teaching. He's the executive director of eHealth Africa, and he is the pioneer of strategic solutions for reporting disasters in northern Nigeria, such as Avado and the mobile community-based surveillance program. He also is the chief executive officer of EHA Clinics, and that's an organization with the mission of providing primary health care plus with the state-of-the-art facilities in Lagos and Kano and a slew of community health extension workers. I would like us to start by watching the video, and afterwards we will welcome Mr. Adam Thompson.
In August 2014, a heroin interesting. In August 2014, a heroin-interesting white died to save Nigeria. From what, you may ask? From an outbreak. Ebola. Her name? Dr. Adadibo Stella. Nearly 12,000 precious lives were lost in the 2014 to 2016 West Africa Ebola outbreak. Just last month, dozens were killed in a massive landslide near Mount Elgon, Uganda. Every year, Africa loses about $1.6 billion due to natural disasters. Clearly, Africa bears a heavy burden of outbreaks and disasters. Thousands of lives have been claimed, scores rendered homeless, helpless, lifeless. We still deal with outbreaks of cholera, viral hemorrhagic fevers, conflicts, and natural disasters. We need to revise our approach to combating these challenges and reposition ourselves from a merely reactive standpoint to an anticipatory and proactive one, saving Africa and indeed saving the world. We must get it right. We are Africa.
Please put your hands together for the organizers. With a warm welcome, I would like you to put your hands together for Mr. Adam Thompson. We can do better.
First, I want to thank the organizers for inviting me to speak and get to network and meet so many young medical professionals and students. My background is not in medicine. My background is in computer science and information technology. And about 10 years ago, I got involved in the public healthcare space while I was looking for technology solutions for particular public health problems. While I was a university researcher. And then after doing that university research for about 5 years, my research partner and I decided that it wasn't enough for us to kind of sit in the university and talk about these problems that we could solve with new technologies, but that we needed to kind of go and give ourselves an opportunity to start that. So we both kind of quit our jobs, closed up our research positions, and started eHealth Africa. And we started with a focus on looking at how technology, data, and information systems could drive improvements in public health, whether that's maternal and child health, vaccines, or emergency responses. Since then, we grew our program a bit. We realized that while data and information systems was something that was central to the work that we were doing, we wanted to make sure it was across all areas. We realized that when we tried to go in and solve just the technology or just the data problem, there are so many other problems left unaddressed in both a primary healthcare setting and lots of other settings. So we tried to build a team. eHealth Africa now has about 500 staff across Nigeria and another 250 staff in a few other African countries in West Africa and Central Africa. And we're spread across these functional areas in health delivery, public health emergency management, disease surveillance, laboratory and diagnostics, and nutrition and food security. Today, I only have time to focus on public health emergency management systems, but obviously we have time to discuss on the panel and answer other questions. So I wanted to be quite quick about this. So emergency management sounds quite complicated. I promise you it's not. Like, emergencies are complicated, but public health emergency management is just that, it's management. It's about organizing things in a particular order, removing layers of bureaucracy and decision making and getting things done with urgency. What we do is we organize our emergency management focus in kind of 3 basic areas. Whenever we're kind of tasked with a new emergency, we look at 3 areas. And when I say emergency, we obviously did a lot of work on the Ebola response, and that kind of comes to mind. But we treat other public health concerns as emergencies. So we started working on, in about 2011, 2012, we were brought in to support the polio eradication effort. What we did, the teams working on polio eradication, on vaccine developments, and getting vaccines out the world was amazing work. But what we came in and were asked to do was convert the program into an emergency response. And to do that, we took that whole approach. We set up emergency operations centers in 6 states plus the national at the national level. And then we looked at these 3 areas, like where can we have an impact? So the first was just basic infrastructure. Like if we need teams of people to come together and potentially, if needed, work 24/7 until polio is eradicated, we needed a place for them to work. We needed the power to work. We needed the lights. We needed the lights to stay on. We needed really good communication with outside parties, and then we needed all the supporting facilities and transportation that would facilitate this. Then we needed management systems. Management systems are like you imagine. And when you start doing emergency management training, if you go online and look for courses in incident management, public health incident management, one of the first things you'll learn is how to run a meeting. So if you ever had trouble and you've sat in a long meeting where nothing ever gets done, those are things that destroy emergency responses. So one of the first rules of emergency management, incident management, is really, really effective and efficient meetings. And again, this sounds really easy and boring because it is. It's really just about removing these bureaucracies and these formal processes and long meetings that don't get anything done, and replacing them with really fast, really efficient meetings where decisions can happen often and as often as they need to happen. Management's also about setting up structures for management. So a lot of things like delegation. Delegation can be really difficult in certain environments, and so to set up those structures in an emergency operations center where if you delegate someone a responsibility for coordinating lab systems for an outbreak to someone, that person you delegated to has to go out and do that work. They can't be calling you back saying, oh, am I allowed to do this? Am I allowed to do this? Am I allowed to do this? You've given that to them. They have to be empowered to do it. You can't keep going back and going to the boss and asking the boss if you're allowed to do this. Because again, in an emergency situation, emergency operation center, that doesn't work. You need to be able to delegate responsibility and trust the person who's going to get it done and trust them to do it and trust the team to do it. And that delegation is really hard. It's really hard for some of us, in leadership roles to kind of let go and assume that it's going to work. But that's how management systems work. And then we really focus on information. So data systems for planning and response, monitoring, evaluation, could go on. I mean, we use these data systems to drive everything from how vehicles get from point A to point B, what they need to carry when they go there. We look at demographic models. We look at demographic models for where people are located and what are the densities of population. And then we also, when we organize these vaccination campaigns, there's a lot of data that has to come back. And so we with the polio response, we gave every vaccination team, we gave about 24,000 vaccination teams a mobile phone, so they could carry it with them. It would connect to data, it would send a GPS location, I think every 2 minutes, so that at the end of the day, they didn't have to call us and tell us all the places they went. We could look at the data and we could say, okay, you went there, there. You were there for long enough, and we can start to make decisions and judgments for the data before the teams even returned home to give their reports. This is really hard to see, sorry about that. But so in our emergency management category, we've got several projects that cover everything from actual response activities to activities that support preparedness. So that one there in the middle says Lake Chad mapping, and so we're supporting the Lake Chad Task Force, which is a polio eradication task force, but also supports routine immunization. Just like in Nigeria, the motto for the polio eradication effort is every last child, right? And that's what really drove us when we started designing systems, because it's not how many children can we get to today. It's not, well, we've only got this much vaccine, so that's all we're going to vaccinate. The motto is every last child. So that means you have to think about the systems that go into this to reach every single child, which means you have to first know where every child is. So that's why we engage in so many of these large-scale mapping efforts. We mapped 500,000 communities in the northern part of Nigeria, including the Lake Chad Basin. Communities that had, until that date, been off map. I mean, hundreds of thousands of zero-dose unvaccinated children were discovered just in the first couple of years of that mapping effort. Just because it is a really vast space, and a lot of places are left off those maps. The rest of this I'll go through. Like I mentioned with infrastructure, I mean, again, a lot of it's simple things, some of it's cosmetic, just to make working spaces. So when we're in, actually this was, oh shoot, where is that? This was in Borno. We were asked to set up a data center there for the team that manages the data systems. The building on the left is what they said, well, here, put it here. And the typical thing would be to go in, maybe put in a generator, drop some laptops off and move on and say we were done. But we realized that wasn't going to be a conducive environment for a group that we wanted to run the data systems that would support emergency systems. So obviously we had to fix it up. We needed to run all the time, so we needed to have power. So almost every project we do in Nigeria has a solar power component now. because it needs to run, so we need to remove the guesswork out of it. And then we do a lot of work with the telecoms companies, MTN, Nine Mobile, Airtel. We kind of, they're on call like all the time. When we set up a new operations center or set up a new response area, we call them and we figure out where's the closest place we can get communication. We set that up day one, so that we don't have to be running around trying to figure out how to text people to get the internet to work. Management systems, like I mentioned, it's all about organization. It's about team management. Most of the stuff you can get out of a good, how to manage, how to run a meeting book. But there are specific courses, like as medical students, if you want to learn more about emergency management, go online, look for incident management training. It's really straightforward, really simple, really clear protocols and processes to follow that you can get a group of students together here at University of Ibadan and have an emergency operations center tomorrow. If you do some googling around. Management systems also for planning as well, because again, a big part of emergency management is preparedness. So it's where things are going to go, what skill sets do we need? Do we know where all the doctors who have field epidemiology training, do we know where they all are? Like, if we need to call on them tomorrow, where are they? And just planning these systems and preparing for when you do get that call, knowing where you need to be and who needs to be there. And I mentioned information systems. A lot of it was mapping because we're trying to identify where people are and where different infrastructures are in place and really building out the map. So we kind of started with what was on the left, and by the time we were done in certain parts of the north, which we've now extended to all 36 states as well. So detailed settlement by settlement mapping with estimated population details are now available for all 36 states in the FCT. Through this project. I'll go through the reporting real quick. I'll just quickly hit on this. So what I wanted to really hit on is that there's still work to be done in emergency management systems, and it's still an evolving process. And what I really want to emphasize is that we really have to decentralize this process. Waiting for the federal government or the state government to set up an emergency operations center and do these things. In the U.S., we started a process. They started a process of where they have a hospital-based emergency management system, right? So individual county and district hospitals set up their own EOCs, because if someone's showing up with an infectious disease that's diagnosed, the place they usually are going to be is in a hospital. So that should be the place of first response. You shouldn't have to wait to wake up, the governor's assistant in order to declare or start the process of responding. You should start at that first place that you see that person. And a university or teaching hospital is an ideal location to set up those emergency response teams so that you're ready, you're prepared, and you know how to activate, you know how to make those decisions. The second thing I will say is that we really need to make more strides in primary care. We need to be seeing these potential threats to health security sooner and sooner. And the only way we're going to do that is by really investing in primary care, and this is by having actual trained professionals in primary care that know how to respond to these things and diagnostics that support it. And that's why the last one there is about improving diagnostics. Sorry about the slides getting messed up. But that's how we're also going to identify these much easier as well. Like, if we have to be sending samples to Europe and the US and even to Lagos in order before we determine if that outbreak is real, that's really going to put us all at risk. So that's my 10 minutes. So thank you.
Thank you very much, Mr. Thompson. Please, another round of applause for Mr. Thompson, please. So we will now get down to the discussion. However, I'd like to introduce the rest of the panelists. I would like to start by introducing a hero. He is the country director of the WHO in Nigeria, the officer in charge of the WHO Nigeria office. However, I call him a hero because the United Nations Under-Secretary General in 2016, Karen Langren, mentioned him as one of the 3 individuals who was responsible for halting the Ebola epidemic in Liberia. He, despite all odds, went against UN security advice and stepped into Lofa County in Liberia and mobilized the community to put an end to Ebola. He is famous for saying, "You need to know Ebola to fight Ebola." Now, gather your people, let's get to know Ebola. Please put your hands together for Dr. Clement Peter. welcome, sir. I would also like to welcome a third panelist, a visionary. She is known worldwide. She is an entrepreneur, an emergency physician, an author, a public speaker, and an investor. She is also a helicopter pilot of great renown. She is the founder of West Africa's first indigenous air ambulance service, the Flying Doctors Nigeria. Please put your hands together for Dr. Olamide Brown. Thank you very much, ma'am and sirs, for joining us in this panel discussion. We would like to start this discussion in earnest. However, to drive home a point, I would like to conduct an exercise. Everyone, please bring out your mobile phone and dial 112. Please, I want everyone in this conference to bring out their mobile phones and dial 112. I would also like a member of the audience to volunteer the response they got. 2 members of the audience to volunteer the response they got. The lady in blue at the back. Any other person wants to volunteer the response they got? The lady in blue at the back, please give her the microphone. Ushers, please could you give her the microphone?
The response is, I'm sorry, the number you called is not allocated.
Anybody else volunteer another response they got? Yes, sir.
Thank you. I'm Mohammad Kazim from Ahmad University, Zaria. The response I got is, sorry, your call could be completed at the moment. Please try again later.
Thank you, sir. Is there anyone seated in this hall who got a response when they dialed 112? I didn't think so. I would like to inform everyone seated in this hall that the number you tried to dial is the emergency response number of Nigeria. God help us if an emergency occurs in this room. So with that, we would like to start this panel discussion. And the question I'd like to use to open would be, where are we when it comes to disaster management in Africa? How well are we doing? What does your scorecard look like for disaster management and outbreak investigations in Africa? I'd like to start with you, sir, Dr. Clement.
Thank you very much. And thanks to the presenter, Adam. I think before we ask ourselves where we are, let's understand the context that we find ourselves in. Our continent has increased risks and vulnerability. Our continent has a weak health system that we are trying to battle with. The whole aspect of the global health security is trying to wake up after the devastating Ebola outbreak in West Africa. The issue of community and the stakeholders, the multi-stakeholders engagement in health has been weak and is trying to come up. This means we still have challenges. It means we still have challenges that we have to deal with in terms of addressing public health events or threats, including disasters. And of course, what did we learn out of this. We learn strong leadership is critical for us to address, as well as disasters. We learn strong partnership is required. That involves all key stakeholders working together. We learn functional surveillance system or early warning system is critical for both disease outbreaks and also detecting disasters. We learn a resilient health system and a resilient community is critical if we need to fight outbreaks as well as disasters. The presentation we had before had one statement: we should not be firefighting. We should be proactive and be able to fight, prevent, or mitigate disasters and outbreaks before it happens. And indeed, that is a drive towards the attainment of the health security in every country. And I'm glad that that is factored inside in the SDGs to take it back how it's been. I'm glad that our government have subscribed to it as part of lessons learned, but also keeping us safe. Now, where are we? Despite all these issues, some battles have been won. It may be slow, but it has been won. You take the Ebola outbreak. Though these countries, affected countries, did not have the capacity, when you compare Nigeria and other countries within the South region, the response capacities were different. It shows that these battles can be won. Outbreaks that have happened, yellow fever, these have been won. Polio, Nigeria is one of the biggest countries. I think 2 years, there's no case of polio. It shows that some work is happening in the front of addressing outbreaks. Disasters. Examples were highlighted in Uganda, in Syria, not close by, where people's lives could have been saved. It happened. Are we making efforts? We're making slow progress, but we're reaching there. What makes it slow? This perhaps the question you should ask. The whole aspect of engagement, multi-sectoral thinking around all these areas. Whether disaster, whether disease outbreaks, they end up in the hospital. When we do planning in the cities, how good are people informed, for example, blocking waterways such that we create floods that cause disasters to us? How engaged are other line ministries in ensuring that we protect the life of the people? I think the conversation will capitalize on that, but the thinking that the governments have in terms of protecting their people is paramount.
Thank you very much for that, sir. So the system needs strengthening, we need partnerships, and though progress is slow, we're getting there. That's the summary of what Dr. Clement would like us to do. Dr. Brown, you're a foremost person in emergency health service delivery in Nigeria. And you lived in 4 continents, if I'm correct. I'd like you to enlighten us about where do you think we are in disaster management in Africa, and what's your scorecard like?
All right, first of all, I'd like to say a big good afternoon to everybody here. Well done for making it here. Those that are in Ibadan, those who are based in Ibadan, those that are coming from abroad. So how many people are based in Nigeria in the audience? And how many people came in from West Africa? So yeah, a big thank you for people people that came from outside Nigeria. A big thank you for people that have traveled into Ibadan. I think it's so important for young medical students to be able to get together like this and discuss some of the issues. Because I think that you have a much harder job than we had when we were training. When we were training, and definitely when they were training, the normal career path would be to graduate and get a steady job, right? Go to a hospital, look for a residency, get a job with one of the development organizations, work for a charity. But I think that if we're really going to change the story around healthcare, especially emergency healthcare in Nigeria and across Africa, you guys are going to have to do a lot better than us. You see, the situation is right now that a lot of the problems in healthcare, and especially in emergency healthcare, are not necessarily clinical. They're not about diagnosis or about pathogenesis or about prognosis. They're about the economics of our continent. So if you look at the Nigerian healthcare budget, it's about $1 billion for 180 million people, which means that each person in Nigeria has about $6. If we can actually get the money for the budget together, we have about $6 per head for each person in Nigeria. When you look at countries like the UK, they have a budget of $250 billion for healthcare in their countries. And that's just for 60 million people, which means that per head, every person in the UK gets $4,000 per head for healthcare. We only have $6. Now, I told you that our budget is $1 billion federal, and their budget is almost $250 billion. So that means that it would take Nigeria over 200 years to budget what the UK spends in 1 year for healthcare. So there's a huge imperative for us across Africa, not just to do more with less, but to think of innovative ways to do better with less. And not just to do better with slightly less, to do better with a lot less. So we can't copy and paste the solutions that we see in the UK or Norway or America. American budget is what, $1 trillion, they're spending $10,000 per head. We need to see what we can do with $6 or maybe $7. Even if they increase it, it will not pass $10. So the challenge to you as medical students coming out of medical school is to get into groups like you have done, come to conferences like that, and not just think about how to get a new job with the hospital or a residency program with the development organization, but I hope that some of you will also be thinking about how to use technology, how to use emerging technologies, how to use innovation to help us achieve that goal of not just doing slightly better with less, not slightly more with less, but a lot better with less resources to do it with, and coming up with new solutions that can bring benefit to every citizen, not just in Nigeria, but across Africa. Thank you.
Thank you very much, Dr. Brown, for that lucid. Dr. Brown, Dr. Clement have both spoken, and from their speeches you would get that the challenges are daunting. Now I'd like to ask you, Mr. Thompson, what are the challenges you've experienced in your work in Nigeria and in Africa at large to delivering quality care in emergency situations? What are the challenges you've experienced in your personal interaction in these fields?
Well, I think we're yeah. Well, obviously, I think the challenges are many. I do want to touch on that. I mean, like what's been said, obviously there's been progress made. I mean, 10, 15 years ago, when I started visiting Kano, you would see, outbreaks of things like, meningitis in the dozens, even hundreds of people. Now on a, those things are down to, 5, 10, 15 in a particular year. So something has changed, but what's changed is probably not innovations in medical treatment. Like Dr. Brown says, it's been these changes in the economic situation, slight improvements where people have improved sanitation, improved the way that they're going about their daily lives. And that's changing the situation. It's making the risk of certain types of outbreaks less, while at the same time, the growth, population growth, that's not keeping up with infrastructure now is adding more risk. So our biggest challenges when we go about work, I mean, our biggest headaches are access to resources. And not that we're missing resources most of the time. It's that those resources are locked up in processes and procedures in various different ways, especially when dealing with government. So our biggest challenge becomes like, how do we identify resources and find ways to mobilize them when there are roadblocks in place due to bureaucracy or turf wars between departments or agencies and things like that.
So bureaucracy seems to be a problem identified. Dr. Campbell, what do you think about that? Bureaucracy hindering delivery of quality healthcare in emergency situations. Is that a similar experience? Is that something you would like to say to that?
Thank you. In terms of the emergencies, I think one of the critical instruments that all countries are subscribed to is the international health regulations core capacities. That has three aspects to help us in terms of attaining health security. One is the preparedness aspect. It helps us to be adequately prepared. It helps us to be adequately detect whatever pathogens we are dealing with. It helps us to respond robustly. So this is a critical, and it is something that most of our countries globally have subscribed to it. And I'm happy to say the process was stepped up after the Ebola outbreak. Countries have had the capacity to have been independently evaluated in terms of the core capacities. And every country that has been evaluated was able to develop the National Action Plan for Health Security. And I'm happy to say Nigeria will launch this probably next month. That becomes a tool, an instrument that helps us to be able to take the capacity, improve Nigeria's capacities in terms of high and core capacities. And it's very important we support that process.
So saying that and that Nigeria is on track. Thank you very much, sir. I'd like to ask you, in your speech, when you were talking about changes that we need to make, you said we need to work harder. Now, before we get to this, that's the youth, readiness to this government, I'd like you to tell us, are there other stakeholders you think need to come on board? Think we should be involved in this process? Dr. Bennett is talking about the process that comes in holistic care in emergency situations. And then other stakeholders, private stakeholders, for example, do you think this is going on? What exactly capacity or capacity?
So, like I said before, I think most of my talks on healthcare now are nothing to do with clinical medicine. They're more to do with the financial constraints that we face. And I think that there's a number of stakeholders that can help us in terms of being able to find the finance to be able to provide quality emergency care. But one of the biggest issues for Nigeria right now, in terms of the government, is our fiscal constraints. So we set a budget. Our budget is about $20 billion, and 70% of that budget, almost, is spent paying back debt. So we don't really have enough money for healthcare or education or infrastructure, because our biggest expense is actually money that we've already borrowed. And if newspapers last week, we've just borrowed a lot more. And as we continue to borrow, people get more afraid to borrow. So I'm in business right now, and I borrow at about 6 to 7% on the dollar. Nigeria, as a country, with all the sovereign guarantees that they have, had to borrow last week at almost 10%. So basically, right now, I'm more reliable than my country. The more we continue to borrow, the less invested, comfortable money, because the capacity to pay back is less. So I think that the government needs to work with some of the people that have borrowed us money in the past to maybe restructure some of that debt, so that we're not spending so much money on paying back debts. And then even out of the 30% that is left, almost 80% is used to pay 1 million civil servants, leaving a very small proportion to invest in things like healthcare. So I think the first set of stakeholders would be amongst the government and some of our financiers to see if there's any way where we can come to a more sustainable approach to our fiscal situation in Nigeria. The second group of stakeholders, of course, I have to mention the organized private sector in healthcare. Private sector delivery brings a level of efficiency and innovation and agility that most public institutions cannot do because of the bureaucracy that we spoke about. So apart from the federal government and our financiers, I also think the organized private sector should be allowed to have more influence in healthcare to bring about that kind of efficiency, the kind of standards, the kind of agility that private enterprise and the profit motive brings into healthcare. The third group of stakeholders that I think are very important are our donors. There's lots of money that has the potential to come into Nigeria. However, a lot of that donor money is erratic or based on what is fashionable at the time. So we end up with 3-year projects or 1-year projects or 5-year projects that might not necessarily contribute to our overall aims in terms of a 25-year plan or a 20-year plan that we have for healthcare. So I also think that the third group of stakeholders that we need to consult with are our donors, to find out whether we can work together, we can show them our strategic plan, and see if they can make longer-term investments into our healthcare system, as opposed to the faddish, erratic, fashion kind of things that we sometimes see right now. So with the combination of the donors, the private sector, and the government and our financiers, I'm sure we can find a much more sustainable way of financing emergency healthcare and healthcare in general in Nigeria. Thank you.
Thank you very much, Dr. Brown. Thank you. We're talking about stakeholders, and Dr. Brown has talked about donor agencies, she's talked about the government, she's talked about private sector. I would like to talk about a group of stakeholders that we all know, and that's the group of stakeholders called the community. Dr. Clement, during the Ebola response in Lofa County, you were renowned to have mobilized communities that were at war, and you were able to turn 30 communities that were at the brink of another civil war to work together to put an end to Ebola in the epicenter of Ebola in Liberia. How important do you think the community is when it comes to being stakeholders in emergency situations, and how do we mobilize them?
Thank you very much. The community is a fundamental aspect of our response, our planning, our response. Without the community, we will not achieve what we want to achieve. That's where issues start. And that's why issues are to be addressed immediately if we want to avoid spread of an outbreak. One could say, in that particular remote village, if we are able to report that problem, to know what it is, to solve it at that point, then we could not escalate this problem to become an issue perhaps affecting a complete state, affecting a complete country, and spread to neighborhoods, to neighboring countries. So the role of the community is very important. This is conversation in terms of us being able to address Outbreaks and disasters, we need to have a resilient community. A resilient community, the people should know the information, they should know what to do, they should know how to report, and they should know how assistance they can receive assistance. I think that is a critical in these two areas. Without involving the community, we are failing. Thank you.
Thank you very much, sir. The follow-up question, how do we get involved in this community mobilization? Say, for example, that we have another equal average in Nigeria. How do people in this room get involved in that community mobilization, in that community response to support the program? How do you get involved?
Thank you. This morning I mentioned one point, is that all of us sitting in this room come from a particular family, come from a particular community. Sorry for the microphone. It means all the young men and the young women represent a very important part of the society. The families that you come from, you go back as ambassadors. Your role, giving back to the community, you will help in giving the right message. You will help in reaching all the communities within your neighborhoods. You will help in working with the peer groups, age groups in those communities that come up. So you have a role to play. And I think this is critical for outbreaks and for disasters, because you have a role to play. You are the future custodians of health. You need to start now. Second thing, probably that we do not have at our age, which you have now, is innovation. You link the presentation we have with the opportunities ahead of us, with innovation. You will be champions to involve the communities in this aspect. Thanks.
Thank you very much.
Thank you very much, sir. Innovation, that leads us to the next vista. However, I'd like to recap that we are responsible for being ambassadors. We are community educators, we are community mobilizers, we are innovators, and this is how we can get involved with disaster management and outbreak. Thank you, sir. You were talking about innovation, and I would like to turn to Mr. Thompson. You're the IT expert. Your company has pioneered innovative solutions to solve problems in Nigeria and in other countries. I know about Avada, I know about the mobile community-based surveillance system, I know about Grade 3, which are programs your company is pioneering in northern Nigeria. Some of them have been scaled to national level. I'd like to ask you, what innovative ways, what technologies could we bring to bear when it comes to combating disaster? There's a lot of talk about GIS and remote sensing and things like that, but I'd like to ask you for your candid opinion when it comes to leveraging technology in solving emergency healthcare problems.
Sure. In terms of innovation and technologies for emergency response, like a lot of them are going to be much more simple than you think. I mean, unfortunately, they're not all easy depending on the situation. Like you mentioned, everyone tried to call this 112 number today. So the same thing, what we were tasked with was supporting this community engagement in Sierra Leone related to the Ebola response. Lots of people showed up. You know, we had from different groups saying, well, we have this technology and this technology. We can use SMS and we can do this, and all these different really innovative, really cool ways of getting reports in. And then the challenge is we just looked at the data, went to the telecom company, and we said, okay, what's the user rate for SMS? They said 3% of subscribers use SMS. So we said, okay, well, forget SMS, that's not going to work here. And then we just, we ended up setting up a very traditional call center. Called the different telecom companies, had them, install lines, do an office, put phones in, put a computer system in, and then used a relatively simple off-the-shelf tool that we could then customize to collect that data and then analyze it in a way that would help drive a response. We added some, and so that's a simple thing. what's nice about Nigeria is there's so much infrastructure for that here compared to a lot of other countries that just have some of those core services not available. Here, if you go online, you can find a company that will set up a call center for you in 20 minutes. You send them money, they'll have 10 people at a desk answering phones for you immediately. It's just about the coordination of connecting these different technologies together and allowing, getting those people, whether it's a government body or NGO body, to go that direction and use more of the private sector, use more of the efficiencies that are being driven out there and bring them in. I mean, the other typical things is, we don't do anything on paper anymore. We don't send people to the field to collect data and scribble down on paper. If it's not collected on a phone with GPS points and timestamps and a bunch of other surrounding data, it's not that helpful to us. Getting back piles of paper, field work is something we just immediately toss away. It's not helpful. We can't do anything with that information. So there's certain of those kind of key innovations and technologies. The next step of new things that are really driving us are more around how do we optimize that field work? How do we use things like field team optimization and AI to really derive and support some of that decision making? So when field teams go out, they kind of know what data to collect, where to go, what communities to target. With these computer systems, kind of helping them along and helping kind of prioritize those assignments.
Thank you very much, Mr. Thompson. So, we understand that two things need to be clear. That we have the infrastructure in Nigeria and in many other countries, but Nigeria more so, and we can build on this infrastructure as private sector organizations or NGOs. We do not have to wait for the government to do that. These are key. Dr. Brown, you run an investment company, Green Tree Investment Company, correct? And your investment company's interest is particularly in technology, exciting tech startups. So I'd like to ask you, what does the future hold for technology in your field, emergency management?
That's a great question. And I think the doctor at the end has already really spoken about the key message that I wanted to communicate, which is, innovation is sexy, and the things that make the most impact are not always the most high-tech solutions. So I didn't actually start a tech company. I just copied what I saw abroad. I thought, there's lots of air ambulances in England, and it makes the healthcare system cheaper because you don't have to build big hospitals everywhere. I grew up in a small town in England, and we didn't have a hospital in my town. Neither did we have any hospitals anywhere around. And everybody had to go to Norwich. That was where the big hospital was. But air ambulance made our healthcare system more efficient because it allowed the UK to be able to centralize and specialize the healthcare system and made it less fragmented. And I just brought the idea to Nigeria and kind of adapted it to Nigeria. So when I arrived here, we had a private jet and a helicopter, and I realized that perhaps this would be too expensive for the majority of Nigerians. So we made deals with the commercial airlines and said, you guys have a problem, right? People can't afford your seats, you're not filling up your planes. And we have a problem. We have a plane, but not everybody can afford it. Why don't we transform parts of your commercial flights into an air ambulance? And it's a win-win situation. So that's what we started doing. And we reduced the cost of a transfer within Nigeria from $20,000 to less than $1,000 just by thinking outside the box and adapting to our own environment and our situation. And I think that that's what technology should be used for. It might not always be sexy. It might not always be drones and 3D printing and AI. It's just looking around at the environment, looking at problems in your communities, in your area, and seeing how these problems can be solved. And that's what I do as an investor. After making profit from my company for 5 or 6 years, I decided to start investing sort of in the next generation of innovation. And I found it very, very difficult to raise startup capital. So I hoped that by becoming an investor and starting an investment company, people could approach our firm. We understand the local environment, we understand Nigeria, we understand the issues, and we know how to invest in Naira and get our return in Naira, as opposed to people abroad that are looking for a dollar return when the currency itself is devaluating so rapidly that you'll never be able to give a dollar return, or it'll be very, very difficult to give a dollar return. So that's what our investment company does. And I'm hoping, really, really hoping, by speaking to medical students and by listening to medical students and other healthcare professionals, that a few people will be thinking about taking this route and really thinking about setting up companies, thinking about the role that technology can play, thinking about scale, and really ultimately thinking about how to create healthier communities across Nigeria. Thank you.
Thank you. Thank you very much, Dr. Brown. So, entrepreneurs, innovators, that's your investment company. She's sitting right there. I would like us to talk about the good. We've talked about bad news, that's disaster. But there's also the good. I'm sure that across the world, I give an example, there's the WHO Risk Communication Intervention, which started in northern Nigeria and delivers life-saving messages from door to door, and was responsible for halting the cholera epidemic in northern Nigeria, in northeastern Nigeria. So we know that there are examples of successful campaigns that mitigate against the negative effects of public health emergencies. So, Dr. Clement, sir, I'd like to ask, are there other examples of successful programs that have halted, stopped this pain? And what could we glean from those examples? What lessons could we learn from them? Could we adapt to our systems to ensure that we get it right every time and not just do trial, this, which seems like what we're doing currently? Examples of successful programs that have halted public health emergencies, and what could we learn from them?
Thank you. I think the number of examples that we can probably demonstrate. I mentioned earlier the issue of the Ebola outbreak, although it took a lot of lives. One example. The second one is the biggest yellow fever outbreaks in Angola and the Democratic Republic of Congo. That's one example that to demonstrate. We had the cholera outbreaks in other countries, which was also contained. What have we learned to avoid repeating the same mistakes? One thing is the political will. The political leadership is very important, led by the government. And this political leadership draws together all the other sectors of the government in a sort of multi-sectoral response that are coordinated through the emergency operation centers. I think Nigeria is a country that is moving on that. The second thing that came out, and many countries have got, is the public health institutes, which Nigeria here is Nigeria Center for Disease Control. This is an arm of institution of government that helps the country to be able to manage, get the intelligence, health intelligence, advise appropriately, ensure that actions are taken. And it also helps. One of the things that as medical students you take from here, let's get solutions to all the problems, new solutions to all the existing problems. We can contribute, or you can contribute to improve the information management, whether surveillance and so on with the new innovation. You can contribute to improve diagnostics, which are critical. You can contribute to improve vaccine development, which is very important. You can also contribute to work on the treatment options, which are very important. All the other outbreaks, yes, countries have struggled to stop them, But I think what is important, the lessons that we take on how we improve our capacity to mitigate, to prepare, detect, and respond early. Thank you.
Thank you very much, sir. Quick follow-up question. We can contribute to improving vaccination. We can contribute to improving diagnostics. How, sir? So people at this conference can go away with that action plan. They know, okay, I can get involved here, here, and here. How can we contribute to improving this system?
Thank you. It is feasible and it is doable that we can make a step. First, health security requires us to be more accountable. Health security requires us to own the process. Health security requires us to be part of the conversation. So we can get involved in being part of the dialogue that contributes to improve our health security. We can be part of the conversation that works to develop frameworks or strategies to help us in addressing the health security. We can be part to implement our national health security agenda. So there is room of how we can get involved. Thank you.
Thank you very much, sir. Thank you very much, sir. As African medical students, we are particularly interested in the progress of our continent. However, there are some things that we think are also important. And I'd like to start by talking about communication. During the last Ebola outbreak in Nigeria, I'm sure members of the audience can be a witness, there were a lot of pieces of information that flew around that were just very erroneous. How many people in the audience remember salt water and bathing with it? Yes. So there were people who reported to the hospital with hypernatremia because they had been drinking salt water, they had been having a vapid salt water. What are we doing about communication in disaster situations? For example, in Nigeria, according to the WHO report last week, there are 7 currently ongoing emergencies that the institution is monitoring. People seated in this room, I'm sure, probably don't remember 1 or 2, and there are 7 in Nigeria. So how are we doing? What are we doing about improving our communication of these health emergencies so people can get interested, so people can mobilize efforts and get involved?
Thank you. Nigeria indeed, as the moderator has mentioned, we are today tackling yellow fever, we are tackling monkeypox, we are tackling cholera, we are tackling Lassa fever. We have the crisis in northeastern Nigeria. I'm not sure how many of us are getting this information. The Nigeria Center for Disease Control has a website. I don't know how many of us are able to access this website. It means there is information gap. And I think the first thing I will do is to ensure the CEO of Nigeria Center for Disease Control networks with all the academic institutions, including medical schools. The information is there. We need to get this information. You need to know what is happening in the country. You need to know what the government is investing to keep us safe. I think that information gap can be bridged so that you are able to see some of these publications that the country is producing. And for you to contribute in this dialogue, we need your energies, we need your talents. It's all of us. It's the security of all of us. So I will bridge that gap.
Thank you very much. Let's put your hands together for Dr. Kelly. Thank you very much. We will need to head towards the question and answer session with our audience. But before we go there, I'd like to ask Mr. Thompson, then Dr. Brown, this particular question, because your area of interest involves technology, and I think that's where we're heading to. I know that in Rwanda currently, there's Babylon Health from the United Kingdom that runs this AI application that provides primary health care using AI. So it's in Africa already. It's not by and by. It's right here next to us. So I'd like to ask, where are we headed in the cul-de-sac, in the region of technology innovation in emergency healthcare services? Where are we headed? Is there a clear path that we're following? Is it that we're having emergency response centers coming up? Are we having medical record services being set up? What's the pathway that we're headed? I'm talking about for private efforts now. That's why I'm asking you and Mr. Thompson. Technology in emergency response, where are we headed in Africa?
Okay, so first, just in terms of some ideas around where things are headed. So you mentioned the NCDC data. So a team from our organization has been working with NCDC on their data portal for the last year. So if you go to NCDC's website now, you will be able to find their epidemiological reports on a weekly basis. They'll email it to you. Put your email in, it'll come to your email inbox every week. So every medical student should sign up for that. You'll get reports from all over the country. So every data that comes into NCDC that for the integrated disease response, it all goes in the database now, and all of it is available online, accessible to everyone. And the CEO is doing a fantastic job of promoting and getting that out there. But obviously, you know, we need to get it out to more students. If you've got assignments in your courses where you have to look at and analyze data, you should be pulling it off that site. It's there. We've loaded historical data. It goes back several years. It's really helpful. The second thing is, you know, is looking for innovative uses of data. We recently are concluding a project that was called Grid 3. And I'm not going to try and remember what all of the letters stand for. But if you look at grid, grid-nigeria.org, I think, you'll see the description. Same thing. You can sign up, create a login, and you get access to hundreds of thousands of data points for health facilities, settlements, roads, police stations, farms, markets, the times they're open, everything, for all 36 states in Nigeria. Again, and what we've been trying to do is go around, because we don't know where all the technology innovation is going to come from. So we've been organizing hackathons. There's one happening right now in Abuja. There's one in Kaduna tomorrow, to bring people together, working in both the public and private space, getting them access to that data, and then trying to provide resources to figure out, okay, what can we solve by looking at all of this data that's coming in, all of this technology that's already there. It's just to now combine it in interesting ways to help us make better decisions, to help clinicians make better businesses, to help people that are looking at new products, new medical products, to quantify their market so that they can know who they're going to sell their stuff to. That's kind of where we're looking. You mentioned ADA today, so this is something as well. Looking at the medical clinics we have now, like EHA clinics, and just a plug, we're always looking for doctors, so look us up and check out for the job analysis. But we're completely data driven. There's no paper in our clinic. It's all driven by EMR, and we have a weekly review of our EMR data where we look at what's happened, what's been, what people came in, what were the tests, and then see if we can identify and fix processes and look at ways that we use new tools like what ADA is doing to automate some of those decision-making processes, to clear some hurdles. So we can actually move some tasks that would usually need a physician to respond to. We can move that down to the nurse because these tools and the EMR and the data is there to help that decision-making process.
Thank you very much. So I hope we all got the opportunities that they're looking for doctors. They organize hackathons so we can participate in. Grid 3 is an acronym for Georeferenced Infrastructure Data for Development. So you can Google that. It's a really exciting project that Health Africa is running, and it's a GIS-based solution that should interest anyone who has a flair for technology and emergency response. Dr. Berger.
Where are we headed? That's such an interesting question. And if I knew the answer to that question, then I'd probably be on my way to being like Africa's first trillionaire, because I would know, right? No investor knows exactly what the next big thing is in healthcare. But we can see indications of where healthcare is going to go. We don't know what exactly will be the next solution, but we know two things about anything that is going to help in Nigerian healthcare. Number one, it must be scalable. So whatever solution that is going to be the next big thing in private sector healthcare in Nigeria must be able to scale. It's not something that's going to help just 100 or 200 people. It's going to be something that affects the lives of millions of people at a time. And number two, I think, is most important. It needs to be affordable and accessible. So it needs to be something that people can afford with their disposable income, and it needs to be accessible. So it needs to be something that people can reach. Innovation is really difficult to quantify, and even some of the biggest companies with the biggest research budgets, like Kodak, like BlackBerry, like Blockbuster, didn't see innovations coming. They didn't see things that were going to disrupt their industry. They didn't see the next big thing. So I think that it's difficult to know where we're headed, but those are the two things that I think I know about where we're headed. Another key influencer of where we're headed is public policy and what the government decides to do with regard to healthcare reform. I've just written a book called Fixing Healthcare in Nigeria, and it's basically a policy guide with some of the ideas that I think would really help reform healthcare in Nigeria. And I think that our policy direction really determines where an industry is headed. So I think you can remember under Obasanjo, for instance, he had Soludo take over healthcare reform. And because Soludo had a presidential mandate to really reform banking, I think maybe it might be too young to remember the time that there were over 100 banks in Nigeria. And Charles Soludo came with a recapitalization exercise because the policy, the government policy, was that banks should be recapitalized. There were just too many banks. Imagine having 112 banks to choose from. There were no accountants to work in the banks. Some of the banks were really small. They were failing by the day. Everybody was working on a staff of the bank. It was really disorganized, and it wasn't delivering any value to the customer. So there was a policy put in place that all of them should recapitalize. And in the space of a few months, they went from over 100 to just 12. And that's why you have quite the strong, robust banking sector that you have today. If there were still 100, maybe 200 or 300 banks in Nigeria and taking over that policy reform, then probably Access Bank that sponsored this bank would be one of those 300. And probably won't even have enough money to sponsor any conference because they're competing with another 200 banks. But it was the policy direction that pushed the banks to reform and to innovate. So I think the policy is very, very essential. And if you want to take a look at my book, it's downloadable from my Twitter handle. My Twitter handle is @NigeriaFlyingDoctor. The third thing that I think is super, super important is the mindset of us being able to leapfrog. So if you remember NITEL, I don't know if anybody's NITEL phones really worked efficiently or that well. Sometimes they work, sometimes they didn't work. But I think it's safe to say that Nigeria never really had an advanced, sophisticated system of landlines. We went over having a system of landlines and went straight into GSM and mobile phones. And in the same way, I don't think we necessarily have to go through the same system that the UK, Europe, America, Australia went through developing their healthcare systems. I think we can jump straight into the future. So I think that these are the three ideas that I'll put out there for anybody that's wondering about what direction to go in, wondering about how to innovate, wondering about where to innovate. Those are the three big ideas that I'll put out there. My last idea is that there's a high rate of failure in these things. Hardly any businesses actually succeed. So even if you do start an innovation, you do start a business and it fails, don't be afraid to try again. Thank you.
Thank you very much. So, let your innovation be scalable, let it be affordable, watch out for government policy, and if it fails, try again. So we'll go straight to the question and answer segment. We would like our wonderful audience to ask questions. I'm an analyst, not an expert, so that's why I'm sitting here. So questions are to the panelists. I will take 2 questions. If there's time for more, we'll take more. But we'll start with 2 questions. Yes, sir. And yes, sir.
question is for Mr. Thompson. Regarding the IT solutions and so on, I come from Sudan, where there is some restrictions regarding the IT solutions and so on. My question is how to implement these IT solutions and so on in a country that is banned by almost every major company that has a relation with the United States. Thank you.
How do you implement IT solutions in a country with restrictions and bans on every major company? He's from Sudan, and that's what they're experiencing there. So how does he implement his IT solutions in such an environment?
All right, good afternoon, everyone. My name is Okwel Ronan from Bo University, Iwo, Osun State. And I'm really impressed. Like, our speakers, you just dazzle every single one. Please, Mr. Thompson, I'm just curious. Where did the organization get the money to provide such high quality emergency response in countries that you mentioned? Then Mrs. Ola Brown, we expected you at Bo University, but then I'm very happy to see you now. Yeah, you spoke on entrepreneurship and then the economies, like that's what we actually need. So for someone like you mentioned you had issues raising capital for your project. So what's actually the way around it right now? Thank you.
Well, first for the question about Sudan, that's obviously challenging. So this really goes to what Dr. Brand said about policy. Right? I mean, the Sudan currently doesn't have any restrictions. They've all been lifted by the U.S. in the last round. The challenge is, though, the kind of policy and commercial hasn't caught up with it. People are waiting maybe for the restrictions to go back on or these things. But again, it's really a policy issue. I mean, this is a lot of the same stuff that we saw in Ethiopia, but you're watching Ethiopia now, everything's changing, policies are opening. Stuff that like people didn't think was going to change for a while, all of a sudden, in the last 3-4 months, things are changing dramatically. So unfortunately, it really is a policy restriction. That doesn't mean that you can't try to look at what technology solutions are out there. But yeah, it's going to take work, and there's plenty that you can do even with the policy restrictions on. There's markets for lots of the technology. You can still get access to some of them while it's going to be quite difficult. But unfortunately, at the end of the day, with policies that restrictive, that's what they're designed for. I mean, unfortunately, they may not think they're quashing innovation. They think they're maintaining control of security or something or whatever. But it really, that's what it does, because there's certain things like with telecoms, you can't get around it. Have your own 3G network without the government saying it's okay. And unfortunately, those are very difficult.
Sorry, a follow-up question to help you. Are there any ideas how you could work around such restrictive policy? Do you have any ideas how you could work around such restrictive policy?
Well, I mean, we might have to talk about that. I mean, we've got teams working in Sudan now. So we know that we've been able to work with the different teams, get technology, and get certain things cleared. It's taken a really long time, but it's happened. And we've got some colleagues, companies. Actually, there's some companies in Nigeria that are it's actually a Sudanese company, but they're the medical distributors for GE. It's actually a Sudanese originally company, but they're in Nigeria. And so, they're a great contact to have in terms of getting technology into the where you need it to.
Thank you. So you could reach out to the EL African Center in Sudan, you could talk to Mr. Thompson after the conference, and you could look to international markets. You don't have to restrict your IT solution to Sudan. Dr. Brown.
Okay, the first question was around policy. And I think when we talk about policy, people think that it's something that is so far away and so distant. But actually, policy, people make policy, right? It's things that people are interested in that become policy. So, I was actually thinking about running for a political office. So I thought I was very reputable in my hometown in Ekiti. And I thought that healthcare would actually be on the top of the agenda. And somebody suggested that I did a feasibility study to see what was on the top of people's minds in Italy. So we did a small feasibility study and we found out that healthcare is number 9. And actually there were a whole host of things that people were more interested in than healthcare. So policy has to do with what becomes policy are the things that people are interested in. So right now, we have an election coming up, and nobody is really talking about healthcare. If citizens were interested in healthcare, then everybody would be talking about healthcare. But it's what we are interested in and what we are talking about that becomes what people say, what becomes the election promises. So it's important for us not to see policy as something distant from us, but actually for us to realize that we have our own roles to play in influencing policy, in creating policy, and if we don't set the agenda, then the agenda will be set for us. And secondly, with regard to policy, I think it's also important that we become more influential as physicians and future physicians. So one of the things that I noticed was when Bill Gates came to Nigeria to set up the Private Healthcare Alliance, the people that he set it up with, he set it up with 2 bankers and a cement producer. Now, there's no issue with that, but it meant that he didn't see any influential doctor or anybody that is involved in healthcare from day to day that was influential to also call to set it up. So healthcare is essentially being controlled by people that produce cement and people that do banking. And they don't have any healthcare business. But they didn't find anybody that was influential enough, and they thought, okay, this person is prominent enough to involve them in this kind of project. So that's also your influence, your level of influence of policy depends on your level of influence as a professional. And when I was watching it, I realized that obviously, like I had as a person become influential enough to go to and say, okay, come on board to my Private Healthcare Alliance. The reason why you call people that are not even involved in healthcare at all is because you call people that you knew, and it doesn't know me or you. So in order to influence policy, I think we also need to become more influential as professionals, and that's really a charge to every single doctor or future doctor in the room. The second question was around raising capital in Nigeria, which is a really difficult thing to do, and a lot of people struggle with it. And the reason why myself and my colleagues set up this fund was to help people be able to raise capital. But obviously, we can't give everybody capital. And raising capital to start, raising capital to scale is always a difficult thing. So the first piece of advice that I would give is, as soon as you start working, or even as your students now, have some personal savings, because most people start their businesses from personal savings. Not everybody can have a rich uncle. So most people actually around the world start their businesses from personal savings. The second thing I would say is also about influence and about networking and about speaking to people and about building relationships. Because the second biggest source of funding is your friends and family, people that you went to university with, people that you shared a room with. I can remember Warren Buffett, for instance, he raised his first capital from his roommate in university. So that's super important as well. And the third group of people are your bankers. Very, very important group of people who can make a difference between, bankruptcy and prosperity. So I'd say also work on your relationship with your bank managers, your branch managers, your account officers. There's no bank MD in this country that don't know his birthday. And if possible, I'll know his wife's birthday as well. Very important group of people when you need, when you're in business, and especially capital-intensive business. And then there's the venture capital funds and the angel investment funds as well. Try and make friends with the people involved in these funds, or people that have raised money from these funds, so you can also approach them and have a warm introduction as opposed to trying to just meet them at a conference and say hi. Try and get a warm introduction from somebody that knows them or a friend of theirs, and that can also help you to raise capital. Thank you.
Thank you very much, Dr. Brown. Round of applause for Dr. Brown. I'd like to ask you for your final thoughts as we conclude this discussion. We have talked about 5 years. Disaster management and outbreaks in Africa. We have talked about how we can move from a reactive system to a proactive system. We have highlighted the role of entrepreneurs, innovators, and we have highlighted the role
of the youth as community mobilizers, advocates, and health educators. Concluding thoughts. Starting from you, Mr. Thompson. Concluding thoughts.
Well, I actually, the last couple of comments, and I did forget to answer one question around how did we get money for emergency response. So, I mean, the emergency response that we first got funds for was the polio response. And, again, it was an interesting pitch. We weren't really known in the polio world. We had a bunch of work that we'd done in northern Nigeria, and we started in Kano, so we weren't even in Abuja, so we were quite unknown. But we came up with the pitch, and we presented it to the team that we knew was working on polio. Showing that what our team could do and what we could do and how we could support the polio program around mapping. We didn't know at that time that the private company that was running the contract to do the mapping before us was kind of faltering. It just happened to be luck. And so when we pitched, they were already looking for a new solution. So we were able to kind of slip in there. The challenge was we said, okay, we can do all this, we can get all this stuff done, 11 northern states, and we can do it for $3 million and map all these sort of things over a period of years. And they kind of laughed at us and said, there's no way. We just paid this company $20 million. No way you can come here and do it for $3 million. It's impossible. Go away. And so we had to kind of rethink, go back, and kind of prove that we had the infrastructure and say, okay, well, fine. We'll make these investments, to make sure we can do it. We still ended up doing it for $3 million, and then having money left over to kind of expand the program to several other states, which was helpful. But we really just had to kind of take that investment. We took what funds we had to make that investment, make sure we had a team that we could put together and pitch it, and we got lucky and it worked, right? I mean, I'm sure there's a science to it in the pitch world, but really it has to be something you care about. It has to be something that you're willing to kind of put your own investments in. I do want to make this comment about the decision makers in healthcare, though, related to who Bill Gates chose, and I do think that's kind of an interesting thing. He didn't pick a leader in healthcare; he picked the leaders in business, and to be honest, that's how. We've recently, our own company has now got involved in the direct healthcare business through clinics, because we realized that while we weren't directly providing healthcare to our own staff, we had to negotiate insurance for them, and when the insurance failed, we had to assign resources to get people healthcare. We realized we're in the healthcare business for 500 people, so and we've gotten quite good at it over time. So now we're take that learning and expand it, and you're seeing this happen as well in the U.S. Warren Buffett, Jeff Bezos just got together and formed a healthcare company because healthcare tens of thousands of people, and they're not getting it from the government system. They're not getting it from the private system. So they decided that take on, and that's the kind of passion that the team that works with me brings to those solutions. They bring to me and say, we're going to create a healthcare company now because we're already in this business and we need it, and it's needed, and so we're going to push forward.
Thank you, Mr. Thompson. Dr. Clement.
Thank you. I think the take-home message from this gathering is that we should minimize these outbreaks and disasters. We lose people, we destroy property, it has effect on the economy. Yet it is doable. Let's encourage and support our governments to ensure that there are minimum capacities to ensure each and every one of us is safe by implementing already the agreed frameworks that the government has put in place and committed to ensure they're executed. The second thing is that we need to have a resilient community where we come from. Community that can be challenged and be able to withstand the outbreaks and the disasters. And not only the communities, but also the systems that are in place. The third thing is that health is our own business, each and every one of us. As individuals, the medical professions, tomorrow you are taking over the leadership of the health sector in the African continent. We need to involve everyone and all the sectors and all the players We need to increase the partnership and the collaboration that exists, because the factors outside the community, outside the health sectors, are the ones playing. You already know from your textbooks, a lot of the problems we have come from animals. They come either from the environment. With the climate change, there are more challenges that we are going to face. And once we are hit with any disaster or any outbreak, we always review our actions, whether we did the right thing or not. We learn lessons. Those lessons should help us to build back better. It could be from the community perspective, it could be from the health facilities level, it could be from the policy direction that will help us to ensure healthy people, and that together will ensure that Africa will be much more healthier in the years to come. Thank you.
Thank you very much, sir. Support the government, get involved, and learn from mistakes. Dr. Brown.
One of the most powerful quotes I have ever heard in my life was from a guy called Keith Moran. He's an American entrepreneur. And he said that poverty isn't necessarily isolation from money. Poverty is the isolation from the kind of people that you need to help you become the best version of yourself. And if you listen to the conversations that we've had over the course of this panel, we've spoken about community, we've spoken about personal effectiveness, we've spoken about relationships, we've spoken about collaboration, and all those things are fundamentally about people and about relationships and about how we communicate with each other and how we share our goals and how we build alliances. So I think my final point will really be a charge to all of us. I mean, there's people from all over Africa. I didn't even realize people had come from as far as Sudan to this conference. To reach out to somebody that perhaps we're not sitting with, or we haven't spoken to, or we're interested in their work, and start the process of building these collaborations and these alliances that we can use to really take a more granular look at solving problems in our communities. Innovation always begins with these, micro collaborations. Two friends, two roommates, two people that have communicated by email, somebody that you met on social media, creating something really amazing. And that's my real final word. Thank you.
Thank you very much. A round of applause for our panelists. Thank you, Mr. Thompson. Thank you very much, Dr. Clement. Thank you very much, Dr. Brown. A round of applause for members of the audience for staying with us for so long. A round of applause for yourself. Thank you so much. And that will be the end of our discussion in the second plenary session of the 32nd General Assembly of the Federation of African Medical Students Association, Ibadan 2018. Please put your hands together for yourselves. Thank you.
Ladies and gentlemen, please another round of applause for our esteemed panelists. Outbreak and disaster management, I must say it has been an interesting and enlightening session. I know we are all tired. It's been fun, right? We have got a day for today, right? Yes, I think so too. So thank you so much for staying with us on the very first day of the 32nd FAMSA General Assembly. We hope it has been educative, I hope it has been informative, and we look forward to having you here tomorrow for a more interesting and educative session. Now, just a quick announcement before we close the curtain for today. As you all know, delegates, you are advised to return back here by 7 p.m. for the cultural night. Yay, who's excited? Woo! Thank you very much, thank you. So please, all delegates, you are advised to represent your country, represent them in their attire, the food. It's going to be a night of networking and fun. So please, go back, freshen up, have something to eat, and by 7 p.m., the organizing committee will welcome you here for the cultural night. And now, thank you very much for that. We're already in the mood. Also, all MSAs, all Medical Students Association that are registered under FAMSA, please, you're to retreat to the rear of the hall for your accreditation for the General Assembly. As you're aware, all member states of the, all Medical Students Association of FAMSA are to arrange themselves for the General Assembly that will be starting by 5:15. The General Assembly proper will start at 5:15. And the other delegates who are interested to observe, please, you're welcome to come and observe the electioneering process of the Federation of African Medical Students Association. Other than that, delegates, it's been nice seeing your faces. I look forward to seeing you this evening. Come prepared, come one, come all. Thank you very much. Have a safe trip back to your accommodation. Bye-bye.